Health Committee and the Senate Health Committee for co-sponsoring this event, along with New America Foundation Campaign for Effective Patient Care. And I want to thank, I don't know if they're in the room, they're probably out in the hall working, but Cloudy Bustamante and Liz Wu and Brianna Gladstone for all the work with this to organize this, to make it look simple and smooth. There are lunches across the hall for you to pick up as you leave. They're box lunches, so you can take them with you, or if you prefer, a few people can sit down in that room and eat their lunch if you like after the event. If you've got cell phones, if you could put them on vibrate. I guess if you've got cell phones, just put your cell phones on vibrate. And then the restrooms are out the hall to the right, go down those two stairs, make a right, and just before the intersection there, on the left-hand side of the restroom. So the agenda for today will go till 1:30. And I'll say a few opening words, and then Michael Weinberg from the New America Foundation. Mike is the Senior Research Fellow for the California program at the New America Foundation. He'll introduce the panel and moderate the Q&A, and then if we've got time, I'll say a few things to wrap this up and send us on our way. So to get started, thank you again for coming, and to say that with the passage of national health reform, and millions more Californians about to be brought into health coverage, it'll be more important than ever to be sure that we make wise use of all resources that we're devoting to healthcare spending, to healthcare. We're hopeful that the conversation here today will provoke thinking about what needs to be put in place to ensure that every Californian can get the best care, the care that is best for them. And so on the one hand, we're living in a time when the evidence underlying health practice is constantly evolving and sometimes dramatically changing. Each year, literally hundreds of thousands of new studies are released related to the practice of medicine. Last year, as part of the stimulus package, the federal government put aside over $1 billion for comparative effectiveness research. And this year, national health reform included the establishment of the Patient-Centered Outcomes Research Institute, which will be looking at comparative effectiveness research work and will have a budget for several years to the tune of about $500 million. That's on the one hand. On the other hand, all healthcare is local. Local is where each communities offer unique systems of care exist and where physicians and patients make their decisions. So this juxtaposition of a national push toward a significant amount of research to be created, translated, and disseminated, coupled with the fact that healthcare is delivered locally, raises a lot of questions, we think, at the state level. It's an important time to look at the state level at what are the opportunities here and what are the responsibilities. And these questions relate to the state's role as purchaser and as protector of public safety and protector of economic well-being for the state. So I'm going to make 5 questions to just put in the back of your mind as we listen to the speakers. One is, what is the role of public policy, if any, and what is the role of the private sector in assuring that physicians and patients have access to unbiased scientific evidence when they're making their critical healthcare decisions together? The second question is there a role for state public policy in assuring that physicians are incentivized to use up-to-date, unbiased information as they make their healthcare decisions? And the third question is, whose role is it to identify the gaps in the use of scientific evidence? Another question is, does the role have a state in encouraging best practices for disseminating new unbiased research? And finally, to what extent should the state be involved in focusing healthcare resources on the care that is known to improve outcomes? So I hope you keep these questions in mind as you hear from our speakers today, who will tell us something about the problems that happen when evidence is not followed, about systems that help support the use of evidence, and about the gaps in physicians and patients. So thanks very much, and I'll turn it over to Mike.
All right, thank you very much, Marianne. And thank you for helping to organize this event and to push this issue forward. And thanks to all of you for being here in the middle of August. Greatly appreciated, and I think it's a testament to the importance of this issue. I'm going to be introducing each of the speakers individually. They will speak for 10 minutes. Note to the speakers, you have to press this microphone button to get the microphone to work. And Molly will be our timekeeper, giving you timekeepers just so you know where you are in the time. So we're going to be starting with Shannon Brownlee, who is an instructor at the Dartmouth Institute Institute for Health Policy and Clinical Practice, and a Senior Research Fellow, a colleague of mine at the New American Foundation. She is a nationally known writer and essayist. Her terrific work has appeared in The Atlantic, New York Times Magazine, The New Republic, Slate, Time, Washington Monthly, Washington Post. And she has a really wonderful book called Overtreated, Why Too Much Medicine is Making Us Sicker and Poorer. This came out in 2007 and was named the best economics book of the year by New York Times economics correspondent David Lender. For all these speakers, they have longer bios in your packet, but I wanted to give you some of the highlights of who they are. So, yeah.
It's really a pleasure to be here. But I'm going to ask you to have a little fantasy for a moment. Imagine you checking into the Four Seasons Hotel, which might be a really good fantasy right now. But imagine that you check into the Four Seasons, and you get into your room, you ask for a non-smoking room, and clearly somebody has been smoking in the room. So you decide to take a shower, you go in, and the towels are piled on the floor. They haven't cleaned the room. And then you go get into bed, and you realize that there are very, very thin sheets on the bed. You would complain immediately to the management, and you would refuse to pay. So in most of our economy, we expect very high quality when we pay a high price. So if you pay $40 to stay in Motel 6, does Motel 6 even exist anymore in California? I remember when I was a student. So you pay $40 and you expect to get thin sheets and a microscopic little piece of soap and no view. You pay $400 in the Four Seasons, you expect to get $400 worth of goods and services. So tell me why we are willing to accept poor quality and poor outcomes in healthcare. We spend an incredible amount on healthcare in this country and an incredible amount on healthcare in this state. And yet, we have been accepting for a long time remarkably poor quality and poor outcomes. And we are paying, in effect, for what is a disorganized and often dysfunctional and spectacularly expensive healthcare delivery system. The delivery system is all of the hospitals and the industries involved in healthcare and physicians and nurses, the whole bunch, the whole industry that's required to give you the care that you get. So if we want to get value for our healthcare dollars, if we want to make sure that every patient gets the right care in the right place at the right time, we're going to have to face up to some very disturbing facts about the system that we have. I know many of you know some of this, but I want to kill some healthcare zombies. So what's a healthcare zombie? It's a lie, a distortion, or just a bad idea that won't die. And there are lots of them about healthcare. So I want to arm you with the weapons for killing healthcare zombies and give you a sense of what has to happen to make sure that patients really do get the care that they want and no more, and they get the care that they need and no less. So my colleagues will fill in a lot of the details on this, so I want to give you the sort of 10,000-foot picture. So healthcare zombie number one, if you go to the average hospital and you have good insurance, you will get the care you need. Well, in fact, that's not the case. A very large study that came out of the RAND Corporation found that patients were, in effect, had a 50-50 chance of getting the care that they need and care that has been proven to be effective. This is undertreatment. Healthcare zombie number two, your doctor knows best. The fact is, a lot of the time, your doctor doesn't have any idea what is best. And that is because we haven't got the kind of evidence that we need. So your doctor can go to one of the top medical schools in this country, and many of them are in this state, and still not know what the right thing to do is. And even with the tens of thousands of studies that are coming out, they still don't necessarily know what the right thing to do is. And I'll give you an example. Usually when I fly into a city, there's going to be at least one billboard put up by a hospital for something called a Da Vinci surgical robot. This is a very expensive piece of machinery. Mostly it's used for prostate surgery, removal of the prostate. And nobody really knows whether or not it is better than a surgeon's own two hands. And in fact, some of the preliminary evidence suggests it's worse in a lot of cases. But the really bad news is that a lot of those surgeries to remove prostates were completely unnecessary. Because the man's prostate was not going, his life was not saved by the surgery because his life was not in danger from his prostate. So the lack of evidence is an enormous problem. And we need, so whenever somebody sees something in the newspaper, what they should be, that says that this is the newest and the greatest, they should be thinking to themselves, it says who? What much as 20 to 30% of the care that's delivered is unnecessary. We're talking about billions and billions of dollars being spent on care that doesn't help patients, and in fact, a lot of it may hurt them. So these are uncomfortable facts, and they're facts that actually affect all of us. They're not just policy, they're not just abstract problems, they're the questions that really affect all of us. And even if you've never been sick in your life, even if nobody in your family has ever been sick in their lives, you are affected because these problems in the system drive up healthcare premiums. But most of us probably have been affected by this on a much more personal level. And I'll tell you about one of the ways that it's affected me personally. My father took a cholesterol drug known as a statin, and he took it unnecessarily. He did not need a statin. And he suffered a reaction that has long been considered rare, but is in fact much more common than anybody realized. And the drug caused his muscles to start to break down, and it nearly killed his kidneys. And he's never been the same since. So the problems in the healthcare system really do affect us all. And what we need, number one, is evidence-based medicine. We need to know what works, what doesn't work, and for which patients. And I know a lot of your constituents and your friends and maybe even you think of evidence-based medicine as something to kind of distrust. And a lot of people think that medicine is already based on science. A very interesting survey by the Campaign for Effective Patient Care showed us that the majority of California voters think that medicine is already based in evidence. And the California Healthcare Foundation conducted a terrific study that found that most people are completely in the dark in terms of understanding how uncertain much of medicine really is. They think that more care is better, they think that newer care is better, and they think that more expensive care is better. So what I want to say now is that there's some good news in here. It sounds like all bad news, but there really is good news. And the good news, believe it or not, is that there's a lot of unnecessary care. That means that we can improve care and we can bring down spending without rationing. Cutting spending does not necessarily mean rationing. Rationing is when you tell somebody that they can't have something that they need and that will be effective. We don't have to ration care in order to bring down spending and improve the quality of care. I think the word rationing ought to be stricken from every healthcare discussion. It has no place at this point. So I want to leave you with three take-home thoughts. Number one, getting better value out of our healthcare dollars does not require rationing. Number two, there are three crucial policy moves that are needed. Number one, we have to invest in the science of healthcare delivery. The Patient Protection and Affordable Care Act has set aside money for this, but California doesn't have to wait for the federal government. You have some of the best medical schools and academic medical centers in the country here, and they are supported at least in part by tax dollars. And they have the power to do something very important, which is to start tracking patients. They can start tracking outcomes in that way. Kaiser's already doing that. Kaiser is light years ahead of the rest of the system in terms of finding out what works and what doesn't, and what they should be doing and what they should be doing. Policy lever number two, comparative effectiveness research is really important, but it's not enough. We also have to revolutionize the way patients and doctors talk to each other about elective care decisions. Decisions about whether or not to have knee surgery. Decisions about whether or not to undergo cardiac bypass surgery. Because really only the patient can know whether they really do need to have that knee surgery. It's really not. And only the patient can know whether or not they're willing to undergo the risks of bypass surgery in order to get the uncertain and generally very small benefit. So I'm not talking about giving patients more information, I'm talking about giving them better information. And I'm also talking about changing that dialogue between doctor and patient. So making that shift is going to require both legislation and training doctors in a very different way. And at least one UC medical school is already doing that, UC Davis. It already has a program for starting to train doctors in something called shared decision making. All UC schools ought to be following Davis's lead if they aren't already. And residency programs need to be encouraged, pushed, cajoled, thank you for patience. And because we have model systems that are already learning how to do a better job. And you have one of those model systems right here in California. If we had Kaiser near where I live, that's where I'd be sending my family. So we need to start looking at how these model systems, these organized systems work. And we need to then try to get the rest of the system to act a little bit more like them, if not a lot more like them. And the transformation is not going to be easy. We're talking about 17% of our economy. And every single one of us has an interest in reform because, in fact, every single one of us at some point is going to be a patient. So for our sake, for all of our sakes, I hope that we're all willing to sort of take up those wooden stakes and those silver bullets and slay the healthcare's lives. Thanks.
All right, Shannon, I'd like to thank you for kicking off with what I expect to be a pretty lively conversation on this issue. For those of you who, I believe there are still some seats here if you want to come, certainly welcome to stand if you prefer. Next we'll be hearing from Sharon Levine. Dr. Levine is the Associate Executive Director for the Permanente Medical Group of Northern California, a position she's held since 1991. This is the group that's associated with Kaiser hospitals and health clinics. She's a board-certified pediatrician who has held multiple leadership roles within the Permanente Medical Group, as well as academic appointments at Tufts University School of Medicine and Georgetown University School of Medicine. She spent 2 years as a clinical associate at the National Institute of Health, Institute of Child Health, and Human Development. Dr. Levine serves on the board of directors of the Integrated Healthcare Association, the Public Health Institute of California, California Association of Physician Groups, the Reggie Udall Foundation, the Medical Board of California, and is a member of the Committee on Evidence-Based Benefit Design of the National Business Group on Health. Dr. Levine.
And I did not pay Shannon for those kind comments about just for full disclosure. I suspect you're going to hear different versions of the same information and somewhat of a different perspective. I think Shannon gave you most of the bad news, and I'm here to talk about what I think is a tremendous opportunity, optimism, and hope many of us feel about what's likely to happen over the next decade. And the first thing I want to say is that I don't think I need to convince anyone who's here, spending some of your time here today, that the passage of what used to be called the Patient Protection and Accountability and Affordability Act, and has thankfully been shortened to the Affordable Care Act, or ACA. The passage of that bill in March of this year was really a historic act. And it has set in motion what is the largest domestic program really since Social Security was passed. It will touch every human being in this country in one way or another, and it will touch many of us very soon. And with the passage of the bill, which everyone, I think, has understood since last summer, the bill was about health insurance reform. President Obama spoke about it as health insurance reform. It was an essential first step in moving us toward the future vision that Sharon was describing. But with the passage of that bill, and most of, as I think you all know, most of the provisions will not take effect until 2014, and will roll out between 2014 and 2018. There are some that happen immediately. We've seen a lot of coverage of that in the newspapers. The work is just beginning, the real work, because health insurance isn't the goal of all of this. Health insurance is just a channel, it's just a mechanism for people to get what they need in terms of optimizing health and getting the care they need when there are risks or threats to their health. Our goal is health for everyone in this population. Insurance reform is the first step, and it builds a foundation, creates a foundation which we can actually begin to look at. So then we're going to have 30+ million people by 2014 who currently have no way of paying for health care other than out of their pocket, who have a claim on this health care delivery system. We have a lot of work to do in the next 4 years in terms of, do we have the right physicians, the right nurses, the right pharmacists, the right number, and the right kind to provide care to these people. There is something for everyone to hate pretty disappointed that the bill largely stopped with health insurance reform, but I don't think we can ignore the fact that there were some very important seeds planted. Shannon talked about one of them, was the substantial investment in comparative effectiveness research. The title of this session today was something about getting right care, right time, right place, the unfinished business of healthcare reform. And I think we need to also be very patient, because it took 15 years for Medicare to be fully governed from its passage in 1965. It really wasn't until 1980 where the pace of amending legislation and regulation slowed substantially. So we need to give this a bit of time before we make judgments about whether this was right or wrong or effective or ineffective. The goal in all of this really is to enable those of us who have made the decision to commit our lives to providing medical care and health care to be able to provide the best possible care to those who depend upon us and those who come to us, trusting that we will enable them to optimize their health and optimize their life. What is the best possible care? It is safe care. It is care that is continual. Care delivery is continually in search of preventable medical errors. We are far from there today, though we have made great strides over the last decade. It is effective care. It's care that is more likely to produce benefit than harm. And the mix, or the ratio of benefit to harm, very much relates to the underlying condition. If you have metastatic cancer, you are more likely to be willing to accept a therapy that has substantial risk. If you have a backache from having played tennis too aggressively or lunged when you shouldn't, you are not going to be interested in discovering 5 years later that the anti-inflammatory pain medication you've been taking increases the risk of heart attack by the same amount as if you've been smoking for 10 years. And that was the case with Vioxx, and I'm sure most of the people in this room know that story. Care needs to be patient-centered, inclusive of values and preferences of patients, not just the biases of physicians. It has to be delivered in a timely manner and in the most appropriate setting. And sometimes in the future, that may be in the patient's home. I think there's a tremendous amount of innovation around communication technology and information technology that will truly transform care delivery, and that many people think may result in about 30% of what is currently provided through doctor office visits being able to be provided electronically, through telemedicine, or in some alternative fashion, where and when an individual needs to get that care. And finally, the care, there was no hesitation about this in the conversations over the last year and a half in Washington. The care has to be of the highest value. We have to ensure that every dollar the healthcare system spends, and those are your dollars, that's your money, that's our money, is delivering at least $1 worth of care. And we've got a lot of work to do. What I want to focus in my last 5 minutes on is what are the obstacles today that prevent physicians and hospitals, pharmacists and nurses from doing what they really want to do, which is to provide the best care possible. And Shannon spoke about the first one, and that is the state of the science and the quality of the evidence that's available today to support best care is far less than what I think most of us would like to believe. The rigor and integrity of the process of evidence development, you all read the same newspapers I do, has really been called into question. We have too many examples of manufacturers, inventors, innovators suppressing negative results, suppressing negative evidence, publishing only positive reports, and really leading to withdrawals of drugs from the market, withdrawals of many people in this country who are taking statins over the cholesterol lowering drugs, you can't go and you can't turn on TV without seeing that obligatory, is to prevent a primary heart attack. And in good faith, cardiologists, primary care physicians have been advising patients who are of average risk that if they take a statin, they will lower their risk of a heart attack. 3 studies in the last month have provided very substantial evidence that, in fact, the benefit is in preventing second, third, fourth heart attacks. But the primary prevention, it appears that statins are much less effective. The issue, I want to talk also about a little bit about the issue of comparative effectiveness research. This became kind of a battle cry for those who were opposed to the health reform bill. Somehow comparative effectiveness research was really going to be a way to say, telling people they couldn't have what they wanted because on average, the average person wouldn't benefit from it. And the truth, it couldn't be further from the truth. Most of the science we have today, the vast majority, is looking at something compared to nothing, compared to a placebo, compared to no intervention. There is no requirement for a device manufacturer, a drug manufacturer, to prove that their product, their innovation is better than anything on the market, is safer, or has fewer side effects. All they need to do is show that it's better than nothing. There is no one who is incented today, other than the federal and state government potentially, to actually do the hard work of looking at things side by side. Say we have 8 statins and 60 antidepressants. For these people, under these circumstances, this is the right therapy. That's what comparative effectiveness research is. So I will close by, I think, reinforcing what Shannon said, is that this is really about getting better science, the challenge of getting that science into a form that's usable in the exam room, on the phone, over the internet, for doctors and patients, giving physicians a better set of answers and patients a better set of questions about why is this right for me, and what else should I be thinking about?
Thank you so much, Dr. Levine. Our next speaker will be Richard Baker. Dr. Baker is Dean of the College of Medicine at Charles Drew University of Medicine and Science and President of the Charles Drew University Multi-Specialty Practice Group. He holds a joint faculty appointment at UCLA, where he serves as Associate Dean at the David Geffen School of Medicine. Dr. Baker is a board-certified ophthalmologist and a fellow of the American Academy of Ophthalmology. He currently serves on the board of directors of the California Medical Association, the Los Angeles County Medical Association, and the Association of Minority Health Professions Schools. Dr. Baker.
Thank you very much. Full disclosure, this is not my sexy voice. I'm just recovering. Thank you for inviting me. And I love what I'm doing. This is really being up on this panel. What I'd like to do is explore what we think might be, or how do we get to the ideal evidence-based healthcare system. I think ideally we want an evidence-based healthcare system locally, a evidence-based clinical encounter to be informed by best evidence and clinical expertise that incorporates patient values, beliefs, and preferences, and in which the interests of all involved stakeholders are explicitly aligned. That last statement is a little bit provocative, but we'll get back to that. I'm a physician and I'm a scientist, and I'd like to briefly comment on what I believe are 3 core concepts central to this discussion from that vantage point. Those 3 concepts are evidence-based clinical practice, evidence-based patient choice, and the nexus of those 2, which I believe is shared decision-making. Each of these powerful concepts is relatively new in the last couple of decades. Each represents a significant paradigm shift from the way we did business before. Each of those is in the process of evolution, and each of those has significant challenges. that I think we are just beginning to address. First, let me talk about evidence-based clinical practice. First, let's go back, and this position's always said. Medical therapy has always been based upon evidence, right? It has been based upon science. But what does that mean? Traditionally, it was extrapolation from pathophysiological theories and unsystematic collection of clinical experiences. So it was evidence, right? It's basically that we thought how things might work. This is now replaced when we talk about evidence-based medicine. We're talking about empirically derived evidence of how effective things actually are, rather than theory. It's important. But evidence-based clinical practice is more than evidence. It's actually the integration of two concepts that are very important. One is actually systematically derived, best available external clinical evidence. But the other component is patient-level clinical expertise. And I'll go back to why that's important a little bit later. There are four actual steps to the evidence-based clinical practice process. First is the framing of the relevant clinical question. And all the questions have not been appropriately framed yet. They need to be framed. Second is systematically searching and compiling the best available evidence. Now, this is a very daunting task. Realizing that I just read, I think there's 7 million pages on the internet that are generated every day. It's a lot of information. Someone who comes into medical school today, by the time they finish their residency, the majority of information they learn will be obsolete. Majority. So that evidence is a daunting task. The third step is the critical appraisal, which is synthesis, validation, and translation of the information into some clinically useful, applicable results. Most of us still do not have that skill set. We don't learn that in medical school, but it's important. And we derive some of that now from guidelines and from other places. The fourth step, again, is critically important. And this is what makes evidence-based care the opposite of cookbook medicine, which many people claim evidence-based care is. It's the application of results to clinical practice. It's the application of that evidence to the relevant setting, to the relevant patient profile, which is critically important. So both of these are important, clinical expertise and evidence. In the absence of current evidence, unbiased evidence, we have a risk of providing out-of-date, suboptimal, and ineffective care. That's clear, without good evidence. But in the absence of clinical expertise, we have the blind application of evidence, and it could be inappropriate to the setting, inappropriate to the patient, and we again risk inappropriate, ineffective, or even harmful care without an understanding of the evidence that's derived. So it's very important. When we talk about, because of evidence-based medicine, we've now changed the definition for clinical expertise. Traditionally, clinical expertise has been viewed as demonstrated proficiency and judgment that clinicians acquire through training, experience, and practice. Because of evidence-based care, expected expertise is now evolved to include the ability to recognize and manage specific clinical profiles relative to available evidence, and to include patient preferences and decision-making processes. Ultimately, what's beneficial from these processes has been mentioned previously. One, it allows, evidence-based allows identification of strategies where therapies are ineffective and the magnitude of their effectiveness. Two, which is important, it allows identification of strategies and therapies that are actually harmful. Three, it allows identification of therapies and strategies that are ineffective. And perhaps just as important as the other three, it allows us the identification of those issues, those therapies and strategies for which we have incomplete evidence and no information. So it's just as important to understand when we don't know. We have significant challenges and barriers associated with evidence-based medicine, as manifested by suboptimal applications of the medicine. But again, what I think we've made, it's important that we started this undertaking, and again, I think we've made move forward. The second process is evidence-based patient choice. This process parallels evidence-based medicine, and again, from the patient perspective, what is the appropriate question? Where is available information? Is it valid? Is it a trusted source? And again, this is a daunting task for the patient. What does it mean? How do you interpret this? And is this information applicable to me? This process, this evidence-based process, actually informs two types of patient choice. One is what I call a consumer choice. That choice that allows them to make comparisons between different settings, providers, and different plans. Also, it's a choice within the clinical encounter, the treatment choice. Again, the challenges are similar to evidence-based medicine and clinical care, but this kind of highlights some of the problems and solutions when we look at patient choice. One, we see clearly that in order to do this, we need to develop, the patients and physicians need to develop specific skills that they didn't have before. There's a need for clear decision support tools to help people make decisions and for decision making. And finally, there's a recognition that the underlying culture, values, beliefs, expectations have a significant influence in how we implement and use these processes. Finally, we have shared decision making. The purpose of this is to empower patients to have a central role in their care by allowing them to express values and preferences, allowing them, empowering them to ask questions, and facilitating active participation in decisions about their care. There are three components, three essential processes to this decision making. One is a two-way exchange of information between doctor and patient. Another is a full discussion and deliberation of possible options and outcomes. And finally, the patient and doctor must arrive at consensus about what to do. This process is intimately and inextricably related to a highly complex interaction between physician and patient. This interaction is culturally, and there's a full spectrum of acceptable expectations for the patient and the physician. It's complex because it goes all the way from fully autonomous patient to paternalistic, and within that spectrum, it's culturally acceptable sometimes for patient or for physician. The barriers to implementation of this are again similar to the barriers of the first two. And finally, we see that for all of these processes, all these two processes highlight the central role of clinicians and patients in both defining and driving evidence-based healthcare. All three processes represent relatively new, rapidly evolving, and dramatically different approaches to healthcare. They're paradigm shifts. All have significant challenges to successful implementation. All are highly sensitive to both the systematic acquisition and skilled communication of information. All are highly sensitive to the prevailing values, preferences, and beliefs. Overall, I think, even though it's imperfect, I think the glass is half full. And what's important is the fact that we've embarked on this process. We're now starting to understand and starting to address those issues that allow us to deliver evidence-based care.
Thank you so much. I really enjoyed your comments. I thought they were both comprehensive and enlightening, and I was really struck by you pointing out that the majority of what the medical students learn will be obsolete by the time they end residency. There's just so much evidence that's out there, and trying to adjudicate which is really going to help clinical encounters, I think is a huge challenge. So. Our final speaker for today is Mary Beth Shannon. She is the director of the Market and Policy Monitor Program at the California Healthcare Foundation, which promotes greater transparency and accountability in California's healthcare system. Prior to joining the foundation, she served as Assistant Vice President for Clinical Services Development for the University of California. She has also been Executive Director for HCP, a Partnership for Health, an alliance of hospitals and medical groups in the San Francisco area, the Benefits Manager for Mervyn's, California, and she's held various management positions at Blue Cross of California.
Thanks, Michael. So the advantage of adding last here is that many of the things that I think I want to cover have been covered by some of my colleagues, so I'll skip over some of this. What I really want to talk about, though, is we have this issue of physicians not having evidence or not being able to sort through the mountains of evidence when it does exist to know what's best. And on the other side, patients who really think they do. They think that the physicians know this stuff, they've been through this training, and so have kind of an expectation that their doctor knows best, and so haven't been very willing to get engaged. And a lot of this has come across in our search at the California Healthcare Foundation to come up with some ways of helping to educate consumers a little bit more about what exists and what doesn't exist and how they can empower themselves to get engaged in this process and participate in shared decision making. So I'm the only person to torture you with slides. Let's see if this works. This is a study that I'm primarily going to talk about this morning that we helped fund. One of my colleagues, Jill Yeagan, is actually a co-author on this. It appeared in Health Affairs last month. Jill's not here to talk about it because she had the good sense to move to Hawaii last month. So I'm pitch hitting for her. But it's an excellent study on kind of getting us that baseline of where are consumers right now in terms of their understanding of their role and what information is available and how to interact in a shared decision-making mode. So when we're talking about evidence-based healthcare, it includes these 4 pieces. Really, everybody so far on the panel has touched on these pieces. Shared decision-making being very important, the existence of evidence, compared effectiveness research. We haven't talked too much about evidence-based benefit design, which is kind of an interesting tool, where if there is some evidence of what works and what doesn't work, within an employer benefit design or even within medical benefit design, we can provide incentives to steer people to the right treatments. And we haven't used that, I think, as effectively as a tool as we could. And then the last is transparency of cost and quality. And I think the problem here is we tried to do a lot of that and ended up, I think, with a pretty cluttered landscape of measures. It's really hard for consumers to navigate. But I think if you're asking people to make a decision, you've really got to give them information they can use in a form that they can absorb and have it available at the time they're trying to make a decision. I think we've fallen short here. So let me talk a little bit specifically about the study that appeared in Health Affairs. It was based both on focus groups as well as an interview of those who had employer-based coverage, so it's not a complete sample, average sample across all of those who receive healthcare services. And it's a national sample, not a Californian sample, of 1,500 employees. And here are some of the key findings that we got. A lot of these have been touched on by the other panelists. A lack of understanding of key terms. And in the little green box on the side are quotes that actually came out of the focus groups. So in this particular case, people don't really understand what medical evidence is. So if you ask someone if their doctor used medical evidence to decide on a treatment, they think, oh, well, medical evidence is what's in my chart, my personal situation. Yes, he used that evidence to decide what to recommend, which isn't exactly what we're looking for here. The second point on this slide is that people have an expectation that all care meets minimum standards, that there are government agencies out there are watchdogs, there are people who are looking over the healthcare system, and they're making sure that the care I get is the right care. These are 2 questions that came out of the survey that Shannon mentioned that have been done by Campaign for Effective Patient Care and their research partners. And it's really kind of consistent with what we found. If you ask people if they think they're getting evidence-based care, they say yes, they think they are. 51% in this case, most or nearly, thought that much of the health care most people receive is evidence-based. And then personally, on their own situation, they think it's even higher. 65% of the care they receive is evidence-based. But one of the issues we're struggling with is, but do they have an understanding, really, in answering this question? What we all know now, which is that a lot of this information doesn't exist, or doesn't exist in a way that physicians can easily access it. And this is just a third version, kind of the same thing. This is from the 2010 report that's coming out of CCHRI, the California Cooperative Healthcare Reporting Initiative, and this is information that can be found on the Ops Patient Advocate website. But it shows across these 4 different domains of care what patients' level of satisfaction is in these various areas. And you can see 90% in terms of MD communication. They're very happy with the communication with their physicians. The next is getting needed care. They feel largely, the 80% range that they are. Their overall care, 70% range. The least satisfying domain here is what is considered shared decision making. They don't feel like they're engaged in making a decision with their doctor. So getting back to kind of the findings in the study, more is better, which Shannon talked about. Clearly, in spite of lots of evidence that that isn't true, people still believe that. They still believe that more care is better care. And interestingly, there's still a lot of resistance to medical guidelines. This concept of medicine, as Dr. Baker mentioned, people kind of don't like the idea of one-size-fits-all healthcare. They want their healthcare tailored to their particular circumstance, and I think largely miss the fact that in some cases there is one right answer for everybody. A couple of other points, their reluctance to engage and to challenge their physicians. One quote from the focus group was, I'm an accountant, you're the doctor, you should know this stuff, how do you expect me to do it? So people don't trust their own understanding of their healthcare options, and they want an expert to choose for them. They're often extremely important decisions that they're faced with, and they don't want to make it on their own. There's another study that I've seen where we asked patients whether or not, if they were ever diagnosed with cancer, if they would want to research and determine their own treatment. And 60% of the time people said, yes, absolutely, I would want to do that. Then when you actually interview patients who have been diagnosed with cancer, the number suddenly falls to 20% of people who actually think that they want to be able to research and engage and decide on their treatment. They want somebody else to make that decision for them because it's so light for them. Personal experience trumps data. People often think that the experience of their friends, their neighbors, their family members is always more relevant, more important to them than some average number. And the second point here, that innovation equals better care. People do think if I'm getting the latest, newest thing, even if it hasn't been well tested, that's better than getting something that's been around a long time. So, faced with all that bad news in terms of what hurdles we have to get over in order to engage patients and get them to understand that this is part of their role as a patient, is to be informed, to discuss options with their physicians. There are a couple things I think that we can do. One is understanding that all consumers, it's not a homogeneous group. Different consumers are engaged and interested and capable of participating in their own care decisions, and we need to be able to provide information to them so that experience can actually happen, but recognize that some patients, it's going to take a little longer to get them to that point. So there's going to be, I think, slow but growing acceptance of this role, and I think the Accountable Care Act will help encourage people to participate more, and certainly there'll be more encouragement for physicians to participate more in shared decision-making. I think the way we message this always has to be about quality, not cost. We don't want to get into the death panel conversation. This isn't about rationing. It's really about getting people the care that they need and no more. And the third element here is I think we have an opportunity to work with trusted intermediaries. People still do believe that there are healthcare professionals who know more than they do. Someone once described this interesting network of nurses across the country, that if you ask people who they would go ask for advice on the care of a family member or even for themselves, the first thing they would do is name a nurse in the neighborhood. They trust them, they know them, and they look for that kind of opinion. So I'm wondering if there's some way we can tap into nursing schools as well as medical schools in terms of getting them to understand their role as kind of healthcare intermediaries here. And then the last is clarifying safe harbors. There potentially are some policy opportunities here in California to make this a kind of a safer environment for physicians to feel that they can engage in these shared decision-making decisions and making available information on optional treatments to their patients. There's one example here. Washington State passed legislation about a year ago or so, which actually did both establish some pilot programs where people were encouraged to have this shared decision-making process and made decision aids available either online, on paper, or even audio visuals that patients could watch in order to understand what their treatment options were and help them decide. It is completely voluntary. Patients can opt out of it. And the last point here is it does provide some provider protection. So that if a physician undertakes a process of sharing all the different treatment options and what the risks are, and a patient chooses something that that physician may not necessarily have recommended and it doesn't work out well, the provider is somewhat protected because they did provide the evidence, provided the information, and it was the patient choice, not necessarily the physician choice. So it's just an option. I'm certainly not advocating that we do that in California, but some states are starting to look at what they might be able to do here. I think I'll stop there.
Great, thank you so much. So we are now going to turn to the part of the program where we take your questions and a few quick notes. If you could phrase your remarks as a brief question.
with Dr. doing so. But again, I think when you look at this, this is a very complex problem because there's two parts of this diet. There's the patient, or the consumer. And I believe that the patient consumer needs to develop skill sets in terms of dealing with this very again complex situation. But beyond that, again, the last study that we saw, this, if we are going to really incorporate values and beliefs and expectations within the care process, evidence-based process, we have to deal with the American psyche. This is why I say it's culture-based. I mean, we're still a society in which, despite challenges with respect to fossil fuel, many of us will buy a home. I mean, we're still a society. This is, to me, I'm not surprised. This is a reflection of who we are. So I think the research really needs to be focused on who we are, and we need to do as good a job as people who market toothpaste and other things.
Just that perhaps we're running into an even deeper problem. Maybe patients want a priest, they want that kind of authority, or on the other hand, they may want a technological miracle. And I think in the American context, all of those desires are extremely strong.
Sir?
I believe my TV talks to me. I don't know if that's an illness or whatever, but I recently went out and bought 2 old bathtubs and put them in my backyard even. That's a joke. Fine. My point is, thank you. How does your conversation get impacted by the TV talking to us as patients? We are inundated with 10,000 messages. Before we get to you who are educating yourselves, it seems like it's an overwhelming battle you have in front of you.
Yeah, I think everybody heard that question. I think that's a terrific question. I'm looking forward to hearing the answers from the speakers. Shannon? No?
Well, as a sort of former member of the media, I call myself a reformed hope pusher. Because I spent a lot of time writing about what was new and wonderful in medicine and sort of buying it. And it's only in the last, I'm sorry to say, only 12 years that I've become more skeptical and more able myself to parse the difference between hype and reality. And part of it, so this is a two-way street again. There's a two-way street between patients and physicians. There is also a two-way street between journalists and the medical industry. And it is unfair to blame journalists entirely for the hype that is printed in newspapers and magazines and on television every single day, because they get a lot of that information from an industry that has things to sell. By the same token, they need to accept some of the responsibility for being unpaid cheerleaders, unpaid promoters. So I'm hoping, and I'm in any way that I can, by talking to groups of journalists, starting to get them to think skeptically about this industry that has a lot to sell. And I think that physicians can do a lot in that arena. Every conversation with a journalist should include this idea that a whole lot of medicine is very uncertain and that we have to really change the way we do things, and they have to change the way they do things too.
Okay, Dr. Bain?
And just to add to that, I think one of the things that is contained in the health reform bill, thanks to Senator Grassley, is a requirement for, I believe by 2012, that every drug company and device manufacturer has to disclose any financial consideration given to any physician over the amount of $25. And I'm not sure that a lot of people are going to be searching that website, but the act of disclosing, I think, is going to be very important. And that the truth is that there's a wonderful capability for self-delusion, and I'm about, and I'm an ethical person. How could I be bought for? You don't really think a $25 gift certificate to Starbucks is going to influence my decision making? Well, the truth is, it does. And there has been social science and medical health services research that demonstrates over and over again. It's not the size of the gift, it's the gifting itself. It is subtle, it's subliminal, that's why it works. And that's why the American people spent $50 billion on
one conference I went to about which device manufacturer had the best bagels as a sort of way to figure out. Yeah. But on a more serious note, a guy that I think really is some terrific insight into this is Dr. Richard Pan, and he, in the task force that we did this year, we have a copy of the report available for those people who want it. He told us about a study that he did which found out that physicians are more likely to prescribe a medicine that their patients saw on TV and asked about, not very surprising, even if they believe that medicine will not help their patients. And so this is not an abstract question. These advertisements on TV are working, and they're having patients take medicine that their doctor may not even believe is going to help them. So it's huge.
Can we ask speakers to identify yourself, please?
Hi, my name is Debbie Ward. I'm from the New School of Nursing at the University of California, Davis. I'm interested about the idea of thoughtful physicians here and others talking about it's important for physicians to step away from a sort of hegemonic position and acknowledge their doubts and uncertainties. Yet at the same time, the discussion, except for a brief comment by Dr. Levine, continues to be doctor-patient, as if that is the sole interchange that's going to make a difference in healthcare. And I'm interested in hearing what people think are the possibilities about an expanded entrance into the healthcare system. Take, for example, chronic illness management, where you may never need to see a physician. You need to see a physical therapist. You need to see a podiatrist. You might need to see the dentist. And yet, the basis for the discussion that continues to be here, even among people who are resisting hegemony, is always patient-doctor, patient-doctor. Would you have any comments about that?
Our cultural biases are shown, professional biases. You're absolutely right, and this gets back to the issue that has become near and dear to my heart, which is a different way of training professionals. And there is, again, language in helpful language in the health reform bill about reassigning training slots for training programs and prioritizing those programs and putting in place team-based training. That is a way of training pharmacists, physicians, nurses, physical therapists together around a shared curriculum so that they have the capacity to operate as partners and as interdependent professionals rather than in a hierarchical fashion. Because you're absolutely right. We don't have enough doctors, and we shouldn't be using doctors to do work that others can do better, can do more thoughtfully, and that plays to a different skill set, but an equally important skill set. It is a process of learning and unlearning biases and habits that many of us have acquired over a long period of time, but it is clearly the way of the future. And I think we're going to see a lot of pilot projects under both state and federal law. And there have been pilots in the state of California. There's a wonderful ability within California to actually do pilot projects that are safe harbors from scope of practice to see whether stuff actually makes a difference.
Absolutely. We too have a new nursing school, fortunately, at Charles Drew, and we are entering with allied health professionals tomorrow. And if you've read some of the work, hopefully, of Clayton Christensen, right, which I think really focuses on what we need. There's an underlying business model that does not support optimal care. And to me, that's really the issue. One is education, and we have to change that. That's clear. It has to be reformed in medical education, healthcare education, so we do it. But the underlying business model does not support optimal care, which I think will always, as long as we have that structural deficiency, we will always hit the wall.
I want to reinforce what Dr. Baker just said. If I'm understanding what you're saying, it's the fee-for-service model of payment that is part of the problem. And when you start paying differently, when you start paying to take care of a patient for a given period of time, some of the business decisions that are made by providers start to shift. And when we talk about shared decision making, there is absolutely a crucial role for nurses, physicians assistants, all kinds of different people who are not physicians to have a really, really central role in that process. Because it takes time, it takes walking patients through complicated stuff, and the physician is probably not the right person to do it. And in fact, even if the procedure or treatment in question would be delivered by a specialist, the specialist is probably not the right person to do it. It is the primary care office with the ancillary people like nurses to help do it.
There are a number, in response to your question, there are a number of tools out there, some of them physician design, I think, especially in drug counter detailing. Jerry Aborn at Harvard, some of Shannon's colleagues at Dartmouth, and put together things modeled on nutritional labels like a drug facts box, so ways that people can get a handle on even fairly complicated information, but in a much more user-friendly way.
Other question? Sir.
You talk about research-based evidence that shows doctor-patient relationship. The larger picture, though, is research-based delivery systems. So we don't have a delivery system here in the United States that's based on any kind of research. The World Health Organization says that we're 37 in healthcare outcomes among the industrialized nations of the world. Taiwan researched their medical delivery system for 10 years and came up with a single-payer system. Our delivery system here in the United States takes at least 30% of every premium dollar goes to administration in our healthcare delivery system. Could you comment on that about what kind of delivery system? I think would be a single-payer system, but I'm open for discussion.
So I'll start. Single payer is the financing mechanism. And whether we have public financing, which is essentially single payer, or a mix of public and private, today the government pays for more than 50% of the care delivered in the country. Or even if there were such a thing, pure private payer system, it still doesn't touch the way that payment gets made. And I think one of the issues that we need to face is what Shannon talked about, or need to address as a country, is what Shannon talked about, which is whoever is paying you, what you get paid to do is what determines how much value is created. So if I get paid, if I'm an orthopedic surgeon, and I get paid to replace knees, it is in my interest to see every limb as a potential knee replacement. That doesn't matter whether it's the government or Anthem Blue Cross. It's paying me as a physician. So the issue of would it be more efficient to have the government be the only payer in a if you will, a private delivery system, public payer? That is certainly something that has been debated. And I'm not sure the answer is in yet. Certainly, we see countries where there is a single-payer system, like the United Kingdom, which has tried to bring in private insurers over the past decade because they think it will stimulate competition in the market. And so I do think we need to keep the issue of how the money gets into the delivery system versus how the delivery system is organized to deliver value.
Right. But I definitely, your larger point, which is that this isn't, and I think that many of the speakers made this point, it's not just about the treatment, it's about the entire system. And so Dr. Baker's comments on the underlying business model doesn't support optimal care, I think, speak exactly to your comments. Sir, and right there.
Have there been any studies on whether or not medicine in countries that have a much longer experience with universal health care and with different payment systems are more effective, especially the European countries that have a similar level of professionalism?
studies that look at us, compare us with other countries that have more facilities of universal health care and different kinds of payment systems, and whether or not results-based medicine are more effective in those countries?
There have been a lot of international comparisons, interestingly, all of these countries suffer from some of the same problems that we do. They just do it for less. So they have a lot of the same problems of undertreatment. They have a lot of the same problems of overtreatment. They have all the same access to the same data and the same issues of trying to get physicians to follow the data and trying to get shared decision-making going for elective procedures. So it's not like there's a magic answer out there in another country.
Yeah, in particular, all countries, regardless of their medical system, whether it's single payer or basically every country has a hybrid system. There are very few. There's almost no countries that have a purely private system or purely public system. All countries have had a big issue, in particular, with rising healthcare cost growth. Many of them are starting at a much lower base than we are, but no one has really been able to figure out how do we get an effective handle on controlling the growth of medical costs while preserving quality. I want to get some other folks in the audience. Ma'am in the front row. Oh, sorry, Marianne.
Okay, please, then I'll go next. Thanks.
I'm Linda Price with Black Sacramento, and my question is expanding on the question about other medical professionals. In terms of how do you see this discussion of medical care interacting with other aspects of primary prevention that may prevent, like how our communities are designed, that may help prevent some of the medical problems in the first place?
Sure, absolutely. Well, I'm going to plug one more time the task force report, because what we pointed out there, and we were certainly not the first people to do it, is that you cannot separate these things, and most doctors, will tell you if you need to exercise more, you need to exercise more, and one of the things that the medical professional community has begun to get on board with in a big way is this issue of, well, you can't exercise if you don't have anywhere to exercise. You can't ride a bike if there's no place that it's safe to ride a bike. You can't eat a great meal if you don't have grocery stores in your neighborhood. And so it's a new issue. It's not necessarily new in the health policy field, but at least from my perception, more and more folks are getting on board with that, and that's an integral part of evidence-based. Marianne?
Next question. Good.
Well, did you want to remark on the...
No, I just had a question, but I...
Sure.
Do you want to remark on
The issue of public health, we know that we're living longer. And one of the really interesting questions is how much of it is due to medical care versus how much of it is due to changes people have made in their lifestyle, safe food, clean water, safe water, and public health interventions. At the beginning of the 19th century, physicians were public health officers. They were expected, or beginning of the 20th century, they were responsible for public health, water, food, sanitation in the community. It was a part of the role. And over the 20th century, health care, medical care, and public health converged. And we're seeing them come back together again now. Because of what Mike has said, it's understanding the non-medical determinants of health probably play a big role in how well we live and how long we live than the drugs we get.
Good, thanks. I'd like to ask this question of Dr. Levine and Dr. Baker, kind of two different questions. One is, and it's about the systems that we need in place to that we want to move in terms of making sure that physicians and other healthcare providers have the evidence they need when they need it. And I know that, Shannon was thinking of the grace of Kaiser. Kaiser's got systems in place, and your BIOS experience and other experiences where you use registries. We just love to hear, comment or two about that, or a description a little bit of what that looks like and how you use your systematic approach. And then Dr. Baker, what about physicians who aren't, and other providers who aren't in such integrated systems? How do we get this information? It's a long process, I know, but what are the
going to do the right thing. And what gets in the way often is physicians are left on their own to figure it out. And I've had the privilege for the last 33 years of practicing in the system where the system doesn't, no one tells me what to do. But the system supports clinical practice by providing information at the point of care, good, credible, and bias-free information. No one tells me what to do, what drugs to prescribe, what tests to order. But with a click of a mouse, I can get access to, in a very fast way, information that either I need or my patient is asking for. And it has, providing information is very powerful. Providing feedback around performance is very powerful. So on a regular basis, our physicians in Kaiser Permanente get reports about what percentage of their hypertension patients are under control, percent of their diabetics are under control in terms of lipids and blood sugar. How many of their patients are not happy with them and are unhappy about the communication level. The combination of, and it's not easy, by the way. This is a multi-billion-dollar investment over a decade to put systems in place to enable this stuff to happen. But the results are quite profound. And we had, some of you may have seen the recent flap over the drug Ivanti, which is the FDA was close to deciding to pull off the market, but I think the decision has been deferred for now. And we looked, we have 500,000 diabetics in Kaiser Permanente in California, 500,000 patients with diabetes. We had less than 100 who were on the drug that was in question. And that's not because physicians weren't allowed to prescribe it. It's because they have respected peers who are responsible for reviewing the literature and making recommendations to inform clinical practice. And that's right there on their desktop. That information is right there in terms of preferences. Now, Mary Beth made a comment earlier about there are some things that are just right for everybody, and I don't think that's actually true. I don't think there's actually anything that you can find that is a standard that is everybody always either has to have it or never should get it. If that were the case, this would be really easy.
Beta blockers for heart attack?
Not, yeah.
Okay.
There's always an exception. There's always an exception, and that's why Dr. Baker's comment about practice-based clinical expertise to be able to start with the evidence, but use the evidence in the best interest of the patient. The world won't be a better place if we start issuing standards or treating guidelines as standards.
How do you get, though, at that moving target of scientific uncertainty and medical uncertainty with the patients, especially patients who want more certainty than you can probably ever provide? It's not exactly a healthcare zombie, but it is something that you hear typically from friends and family that, well, medicine and science thought something 10 years ago, now they think something different. It ends up being an excuse for inaction or sometimes for poor decision making. How do you address that?
I think the honest answer is that that's actually good news. That if we accepted published research as the last answer and stopped looking, we'd be doing a lot more that was harmful than we're doing now. I think we ought to be reassured by the fact that we have a level of inquiry into, quote, settled science that continues to question in the face of new research and drugs and devices. We don't always get the right answer right away, but we do have a mechanism of inquiry that over time it gets better.
So we just have a few more minutes. I wanted to turn to Dr. Baker, and then Marianne, do you want to sum up? All right.
Actually, going back to the last question, clearly we need to learn, physicians need to learn how to embrace uncertainty. The more difficult question is whether or not patients can embrace uncertainty. Because they're the ones driving it. And again, if they demand, if they demand an answer, because they'll just go down the street to the next physician who served, right? That just happens to be it. Unfortunately, so we have to change that.
And Dr. Lee's comment was, I think, a pitch perfect defense of the scientific method, which has sort of uncertain cachet, I would argue, among a lot of people in America. But I hope you're right. I certainly agree with what you said.
So can I answer Mary Ann's question? Kaiser is a great system. It's one of a very small group of systems that are called high-performing systems. It's not a perfect system, but it's good. But again, as you stated by Dr. Levine, that system is incentivized to do the right thing. That system also had to have billions of dollars of investment to get those tools, to support tools. So going back to what you're saying, I think you were spot on in terms of research into what are high-performing systems, because we really have to move to systems of care, right, from the industry that we're in now. We really have to develop those tools that have that deliver information to the point of care, right place, right time, right? And I don't know, we can only do that within a system of care. We need to do research, again, not just on and training, not just for physicians and other providers. We need to do that on the other end to look at how do we embrace the preferences of the patient population in terms of values and preferences and move them to some place that's of benefit to everybody. In the very beginning, and then I'll go. One of the things, provocative question I said, explicitly align everyone's interests. For instance, when you're in a room for that shared decision making, there's not two individuals, two components in the room. Because when the physician or the clinician is in the room and the patient family is in the room, the employer is in the room. The health plan is in the room. So there are other entities that are in the room in terms of determining what happens in that interaction. And again, from my point of view, those should be clear so that we can begin aligning the interests to do something that makes sense.
Okay, so I won't try to wrap it all, and I won't try to reiterate it. I'll just try to say something about what struck me, right? I thought we heard a really interesting combination of sort of the human psyche, and where it's really deeply touched about these things that we care so much about, right? We heard words like fear and culture and hope and self-delusion and uncertainty and distorted objectivity. I mean, just the things that are real, those are not like easy little, she's happy, she's sad. Those are like really deeply held emotional parts of ourselves. And we were talking about that in terms of the provider and in terms of the patient, right? And that we needed to address those. And then we kind of rose up from this kind of really human level to okay, it's skills we need to address those, right? It's not just deeply held emotions. There are things we can do that have to do with our skills, how we approach our humanity and our relationship with our provider. And then we rose to the system level, right, where we talked about, okay, well, how are we going to make this change? How are we going to shift these big norms? We talked about a few different things. One was, changing how doctors are and other providers are trained in school, and how important that is because things, I think it's a different world now, and everything's changing so rapidly, and it really is about how you look at evidence and how does a provider apply his or her intellect and analytical skills to what comes before them every day. And we talked about, what else did we talk about in terms of systems? Training professionals, the business model, very, very important, right? How are we paying folks? What are go back to the human part, the financial drivers that ends up touching us at a very human, deep level. And how do we address that in terms of the systems for how do we pay physicians? And how do we get trusted information? There's a lot of research out there that says that physicians really respond peer-to-peer. That's who they want to hear from, other highly respected physicians. So how do we set up systems that allow, with the click of a mouse, that really good, trusted information to appear before the healthcare provider as they're making a clinical decision. And then I'll just say finally that Dr. Baker's point about involving all the stakeholders. I mean, I think this is a process that's personal, it's in the healthcare workplace, and it's also, some of it's got to be public policy. And how do we do that physician provider encounter, Dr. Davis said the payer is in that room with them. And how do we kind of elevate that and bring everybody to the table so we can have a conversation? I think that there can't be any good guys or bad guys in this. And that's kind of a cliche, but I really do think that in this case, everybody's got to be at the table participating if we're going to move forward to solutions. And as Dr. Levine said, it may take a long time. It took a long time, I guess, for Medicare to get as fully formed as it is. But anything we can do to move that process along more quickly and alleviate a lot of suffering and bring a lot of good is, I think, really important and beneficial. So thank you, everybody, for coming and staying and hanging out and asking some great questions.
What's good to be part of the evidence